Hey everybody, I'm Rachel Palmer. I'm the consultant pharmacist for genomic medicines for the NHS Southwest Genomic Medicine Service. And I wanted to give you an overview today of how pharmacogenomics may impact prescribing in surgery. So when we talk about pharmacogenomics, we're considering the pharmacology of medicine that we already understand and combining that with an individual's genomic makeup so we can give a safer and more effective medicine that's tailored to variation in someone's genes. And as you can see in the graph below, depending on someone's genetic makeup, they can be classed as a normal metabolizer if they don't have relevant variants, or they could also be classed as a poor metabolizer, an intermediate, or an ultra rapid metabolizer. And depending on whether or not you have a prodrug, this can either lead to low plasma levels and treatment inefficacy, or higher plasma levels and the risk of adverse drug reactions. But that's not the only way in which pharmacogenomics can impact prescribing, and we'll talk about some other examples later on. So to give you an idea of scale, nearly every one of us will have a pharmacogenomic variant. Codeine is actually ineffective for more than 5 million people in the UK because they're unable to effectively metabolize it to morphine, and 1 in 500 people are at increased risk of aminoglycoside-induced hearing loss because they carry a genetic variant. So why is it important? Well, we spend a lot of money on our medicines, and they're actually not really working for around 30 to 50% of patients. And importantly, patients, of course, do not want to be taking a medicine and the risk of side effects if it's not actually going to benefit them. And as I'm sure you're aware, there are considerable numbers of hospital admissions that are linked to adverse drug reactions. And of course, this is very significant for patients experiencing these ADRs, but there's only very, very significant cost to healthcare systems of treating ADRs. I just wanted to highlight here, so we've talked about how pharmacogenomics can lead to subtherapeutic or excessive plasma levels and how that may influence treatment efficacy or risk of ADRs. But I also wanted to highlight on the right-hand side that you can have genetic variants, often in the HLA genes, that can predispose someone to idiosyncratic type B type adverse drug reactions. So that's important to bear in mind as well. I wanted to give some examples of pharmacogenomic testing that are happening at the moment in England and the UK. And I wanted to start with DPYD. So this is something that's been embedded for several years now in routine practice in the UK. And this relates to the fact that between 3 to 8% of the population have got a genetic variant in their DPYD gene that can result in accumulation of fluoropyrimidine chemotherapy. So these are things like 5-FU or capecitabine that are very commonly prescribed for patients with colorectal tumours and other solid malignancies. And you might think that 3 to 8% is a relatively small proportion of the population with variants, but it's been prioritised as a test because the consequences of having a genetic variant can sometimes be fatal, and they often result in very severe chemotherapy toxicity that requires admission to ITU and sometimes total parenteral nutrition. So because of the risk to patient safety, this was prioritised for implementation. And now in the UK, any patients that newly started on fluoropyrimidine chemotherapy are tested for the most common DPYD variants. And if a variant is discovered, they're either offered an alternative treatment or they have treatment initiated at a lower dose. I wanted to move on to talk about some of the opiate analgesics and the effect of pharmacogenomic variants. So codeine is obviously a prodrug, as is tramadol, and they're metabolized by CYP2D6. And up to 7% of Caucasian ancestry patients have got CYP2D6 reduced or no function, which means that they do not experience adequate analgesia. Conversely, around 1 to 2% of Northern Europeans, but up to around 29% of African or Ethiopian ancestry patients are actually ultra-rapid CYP2D6 metabolizers. And this predisposes them to adverse effects or toxicity because they're experiencing higher plasma levels. And there have been several publications highlighting the risk and sometimes fatalities associated with the ultra-rapid metabolism of codeine. The MHRA reviewed the use of codeine and concluded that coding should be avoided in patients under the age of 12 years old several years ago. And CYP2D6 status played a part in this, but it wasn't the only factor. However, they concluded for patients of any age, coding should be contraindicated in those known to be CYP2D6 ultra-rapid metabolizers. I just wanted to move on to talk about another prodrug, clopidogrel, and CYP2C19 genotyping. So clopidogrel is activated predominantly by CYP2C19 to its active form. And around a third of the UK population have at least one loss of function allele for CYP2C19. Notably, the rates of loss of function alleles are even higher in South Asian populations. So these are really significant proportions of populations who are potentially unable to effectively metabolize clopidogrel to its active form. And there is data to show that these patients are at increased risk of further neurovascular or cardiovascular events if they are prescribed clopidogrel as secondary prevention. So clopidogrel is often used in lots of different indications and pathways. Some of them are quite complex. So I also wanted to highlight some of the considerations for this. So which patients will you prioritize to genotype? Where will you do this genotyping and how? Importantly, if you decide that clopidogrel is not appropriate, is there evidence for alternative antiplatelet agents in this setting? This test can be undertaken in a genomic laboratory, but there are also at least 2 point-of-care test systems available. And importantly, CYP2C19 can also affect the metabolism of lots of other medicines. So are you going to reuse these results for other medicines? And if so, it's really important that these results are recorded into medical records for future reuse. So the National Institute for Health and Care Excellence in the UK reviewed the use of CYP2C9 genotyping for stroke or TIA patients due to receive clopidogrel, and they published a positive appraisal in July last year, which concluded that these patients should be offered genotyping. They did give a preference for laboratory-based testing, but said that if this was unavailable, then the point-of-care tests were also an option. And just in the stroke and TIA population, this represents a really considerable logistical challenge in the UK because of the huge scale. And because of this, we're undertaking a national pilot to inform how we further implement this guidance. In relation to surgery, the use of clopidogrel and genotyping in peripheral arterial disease is, of course, of relevance. And I just wanted to highlight that the evidence in this particular indication is perhaps not quite as strong. A recent systematic review did conclude that it was too limited to draw a conclusion. But just to highlight, there is ongoing work at gathering further evidence in this area. So as part of the Pharmacogenomics Network of Excellence in England, there's a programme of work looking at this, but there's also a randomised controlled trial ongoing where they're going to randomise patients to standard of care clopidogrel or pharmacogenomically guided prescribing. And if they find a patient has got one loss of function allele for CYP2C19, they're going to give them an increased clopidogrel dose of 150 milligrams a day. And if someone has two loss of function alleles, they will be given aspirin plus rivaroxaban as the antiplatelet strategy. The trial is looking at composite primary outcomes of various cardiovascular and PVD related outcomes, and importantly, it's also going to consider bleeding complications with some of those alternative antiplatelet strategies. So we're awaiting those results with interest. I wanted to move on and talk about two examples of how pharmacogenomics can affect anaesthetics. This one relates to the RYR1 and CACNA1S gene. And actually, across both those genes, there are 50 genetic variants that are accepted by the European Malignant Hyperthermia Group as diagnostic mutations for malignant hyperthermia. And so if a patient has one of those genetic variants, it predisposes them to potentially lethal hypermetabolic reaction to some anaesthetics. Importantly, genetic causes of malignant hyperthermia are pretty rare. So 1 in 2,000 to 1 in 3,000. This is not something in the UK that we routinely test for, but there is international pharmacogenomic guidance from an organisation called CPIC. And this advises that if you do have a patient who has a positive muscle biopsy for malignant hyperthermia, that you do go on and genotype them for those two genes. And if you do find a genetic variant, it's actually advisable to inform family members and consider testing them to prevent future occurrences of malignant hypothermia with anaesthetics. I also wanted to highlight that BCHE genetic variants can also affect metabolism of general anaesthetics. Again, this is not something that's routinely done across the UK, but there are pockets of practice of this. And these guidelines come from the FDA. And these are just two examples. There are more examples I could have provided, but for mivacurium and succinylcholine, the FDA advises that use is avoided in poor metabolizers for BCHE. I just wanted to move on to talk about the role of pharmacogenomics in the treatment of infection. And as I mentioned, about 1 in 500 people have the most common variant in the mTRNR1 gene. So this is a mitochondrial gene. And this means that even at normal plasma levels of aminoglycosides, they can experience sudden onset hearing loss and also inner ear disorders. At the moment in the NHS in England, we do have a laboratory-based test for this gene. It can take a couple of weeks to come back. So with that in mind, we use it where we can predict the use of aminoglycosides. So if we've got patients with chronic disease such as cystic fibrosis, this may predispose them to gram-negative infection. We test them in a preemptive sense and store it in their records. It's also important to say that this, because it's a maternally inherited variant, unlike other pharmacogenomic variants, there is an implication for testing some of the family members. And although this isn't in relation to surgery, I just think it's worth being aware of, because you may encounter patients with some of these chronic disorders who come on to have surgery, and they may already have a result for this mTRNR1 genotyping test in their medical records, which should influence your antibiotic choices in a surgical setting as well. And as well as the laboratory-based test, there is also a point-of-care device for this gene. It's been trialled in neonatal sepsis, where, of course, you cannot delay the administration of antibiotics. And it involves doing a buccal swab, and results are available in less than half an hour. And the National Institute for Care and Health Excellence did review this a couple of years ago. They gave a positive opinion, but NICE did recommend that further data collection was required, and that's ongoing at the moment. But this is something that we could see being used more widely in the next few years. And again, this could be a situation where somebody already has received this test and the results are stored in their record and would be of relevance if you were to be undertaking surgery on this patient in future. I also wanted to highlight some work on respiratory metagenomics that is part of one of the genomics networks of excellence in England. So when we talk about metagenomics, we talk about sequencing all of the genetic material, so whether that's fungal or viral or bacterial. And at the moment, this is being trialled in an ITU setting for patients with severe respiratory infection. It's looking at several aspects. So one of those is, can we use metagenomics to more rapidly identify a pathogen? Of course, that has huge benefits in terms of rationalizing antimicrobials. Can we also use metagenomic testing to identify pathogens that may be resistant to our standard of care antimicrobials? And also, can we do some host immunity profiling to try and determine any genetic variants that predispose these patients to these life-threatening infections? So although this has just been used in the ITU setting and respiratory infection at the moment, if this is successful, this has the potential to be of great use in other areas for treatment of infection in the future. I just wanted to move on and give a case example of how pharmacogenomic variants can cause the idiosyncratic type B adverse drug reactions. And I wanted to use carbamazepine because it's prescribed very widely, including for pain indications. So this relates to patient JK, who is 19 years old and suffered from epilepsy and was switched to carbamazepine. And it initially all appeared quite innocuous. So she had a mild itch on her arms that progressed. And it was considered that perhaps this was a reaction to a new washing powder. However, a week later, she developed sore throat and flu symptoms. The rash hadn't resolved. And unfortunately, she collapsed and was admitted to A&E later that day. And she was found to have more than 5% skin detachment and had developed organ failure. So she had Stevens-Johnson syndrome. And I'm pleased to say that after a stay in ITU, she did recover, But this was as a result of having a variant in her HLA-B gene that predisposed her to this serious and life-threatening skin reaction. And there is some guidance from the MHRA in the UK, which is several years old now, but it does recommend genetic testing in certain populations. The prevalence of the genetic variant is far higher in patients of Han Chinese, Hong Kong Chinese, or Thai origin. So this isn't something that is widely in use in the UK at the moment. There are pockets of practice, and this is something that we could see expand in years to come. I just wanted to highlight, we've given some examples, but I want to highlight that there is a lot of information available on an international level for very commonly prescribed medicines. So at the moment, pharmacogenomics in several countries is still at quite an early stage, but if you look at the guidance available on an international stage, and also the fact that now drug manufacturers are increasingly including dosing recommendations for patients with pharmacogenomic variants, I think it's good just to have this overview to see what may come in future. So we've talked about CYP2C19 and clopidogrel, but just to highlight, there is international guidance available for voriconazole, for proton pump inhibitors, and antidepressants. Again, we've talked about how HLA-B variants can increase the risk of serious skin reactions with carbamazepine, but actually genotyping is now standard of care for patients before they receive abacavir to reduce the risk of the same kind of skin reactions. And there's also an association between variants in these genes and the Stevens-Johnson's or toxic epidermal necrolysis reactions for patients receiving allopurinol. Similarly, we've talked about how CYP2D6 can influence the metabolism of some opiates, but there is also guidance for the management of patients with variants of CYP2D6 for prescribing ondansetron, tropicitron, and several other medicines. And there are also more broadly pharmacogenomic guidelines for NSAIDs, beta blockers, warfarin, statins, and also tacrolimus, which you may encounter in a transplant setting. So there is a really broad spectrum of pharmacogenomic guidance across many different medicines. I wanted to specifically highlight a project we're piloting in the NHS in England at the moment. And this is on the basis that actually a relatively small number of pharmacogenes can affect the metabolism of lots of medicines. And actually, rather than test people in a reactive sense, it would be more effective and efficient to perhaps test a number of the most common pharmacogenes at once and store the results in someone's records for future reuse. So this project is really looking to gather health economic evidence for this approach and to also look at the feasibility. So can we implement pharmacogenomics for very commonly prescribed medicines in primary care, in GP surgeries? Is that feasible? And we are taking a gene panel approach for the following groups of drugs: so antidepressants, codeine and tramadol, statins, and proton pump inhibitors. And importantly, rather than presenting clinicians with a laboratory result, these results are being translated into prescribing advice for clinical teams in primary care. And importantly, they've also made great progress and have managed to integrate these results with some of the clinical decision support systems in use in primary care, so that in future, if somebody is prescribed, for example, a statin, the result may pop up with their SLC01B1 status that may alter your choice of statin or the choice of therapy. So this is a project that we're really excited about, and we hope the results will be available in the next couple of years. So I just wanted to highlight a couple of good resources if you want to look into this further. So in England, we have the Genomics Education Programme, and as part of that, we've got a resource called GE Notes. This is a just-in-time resource, and there are two aspects to the resource. There's a very short, sharp clinical scenario called In the Clinic in the top right-hand side. But if you've got a bit more time later and you want to revisit the topic, there is more detailed information available in the Knowledge Hub. And this is peer-authored and peer-reviewed guidance. There is a work stream on pharmacogenomics. There are several other work streams that may be of interest. And I have mentioned various international pharmacogenomics guidance. I just wanted to highlight that PharmGKB is a website that collates all of the international guidance. So it will include guidance from the Clinical Pharmacogenetics Implementation Consortium, also FDA guidance, and it also includes some online checkers. So one of them is the Genotype Selection Interface, and DNA-driven prescribing, which allow you to put in drug names and genetic variants and check whether there's any association. And I know I've mentioned it a couple of times, but I wanted to highlight that the Clinical Pharmacogenetics Implementation Consortium has peer-reviewed guidance published on their website for a number of different drug gene pairs. So that's also a fantastic resource.